Good afternoon, everyone, and welcome to the DiaSorin CVS workshop this year. My name is Michelle Tabb. I'm the Vice President of R&D for DiaSorin Molecular. So today we have two speakers. We have Amanda Harrington from Loyola, who will talk to us about HSV, and we have Jacky Chow from MultiCare Health System. I wanted to make an announcement right off the bat. We have an agenda change. Dr. Harrington, actually, her plane had mechanical problems in Chicago this morning, and so she'll be our second speaker today. So we're going to switch things around and start off with Dr. Chow. So I just wanted to let you all know that before we started. So first I'm going to start off with a little bit of background about the company as well as the assays we have in development before I hand it over to Dr. Chow. So for those of you who do not know, DiaSorin is an Italian company. We are listed on the Italian stock market, and we're a global leader in biotechnologies. We have a presence in about 60 different countries through direct sales and over 80 countries through a distributor network. And for over 40 years, the company has been developing IVDs. It's only recently that they've become involved in the molecular diagnostics space, though, and it was about 2 years ago now that they acquired Focus Diagnostics and got thoroughly involved in the infectious disease real-time PCR market. The company is headquartered in Saluggia, Italy. It's about 2 hours away from Milan, in case you're ever in Italy and have a desire to come and see the global headquarters. And we have about 1,700 employees, 129 of whom work exclusively in R&D. And our products are designed for hospital or private lab testing, but DiaSorin is known as the diagnostic specialist. They have the commodity assays that are pretty typical, just as we do, but we also have specialty testing, both in the molecular and immunodiagnostics realms. So this map just shows the presence of DiaSorin Molecular globally. So over here on the map, you can see the tiny little booth. For those in the back of the room, it's probably really tiny, but our global headquarters is here in Saluggia, Italy. And over here on the west coast in Cyprus, about 10 minutes away from Disneyland, is where we have our DiaSorin Molecular headquarters. So we have about 180 employees for DiaSorin Molecular, including an R&D team of about 24 here in Cyprus that's developing the sample-to-answer 8-well disc products, which we'll talk about today. But I also wanted to mention there's also a separate R&D team of 20 just outside Milan that currently is developing a fully automated extraction plus disc loading plus viral load transplant assay system for 11 new assays. So we'll be talking about that as we go on through development in future seminars. A little bit of history about DiaSorin Molecular for those of you who are new to this space. So the company was actually founded back in the 70s as MRL, Microbiology Reference Laboratory. And then in the 1980s, the name finally changed to Focus Technologies. And then in 2000, changed its name to Focus Diagnostics. In 2006, the company was acquired by Quest Diagnostics, and slightly thereafter, actually, we finally formed our partnership with 3M, and we have a dedicated real-time PCR platform, formerly known as the Integrated Cycler, which has been rebranded as the Liaison MDX. In 2010 was our first entrance into the IVD market in the US with clearance of our H1N1. And then since then, we have 7 FDA cleared and 12 CE marked assays. And as I'll talk about in a few slides, we have more than 45 ASRs also available for those of you who want to do lab developed tests on the Integrated Cycler or the Liaison MDX. So now a little bit more about our testing platform, the Liaison MDX. So the system consists of 3 different components. So we have the software, the Liaison MDX Studio software. We have the instrument itself, and then we have 2 different disc consumables that allow for both IVD or user-defined testing on the system. The instrument's quite small. For those of you who've been in the exhibit hall, as soon as you walk in the door, you should see some in the booth right there. And the system takes up about the space of about an 8.5 by 11 sheet of paper, so quite small. It really is great utility for the labs, especially when you have a lot of credit space. We have the sample-to-answer workflow available both for the 8-well and the 96-well. You can multiplex up to 4 targets on the system, but we are working on some greater multiplexing capabilities for the system, so please stay tuned for that. We have made melt curve analysis available in our software now, and so look for products coming soon that enable that, and that also allows users to do melt curve analysis if they develop components. Our runs are typically about 1 hour, and as I mentioned, we can use both 8-well or 96-well discs on the system. We have a very smooth workflow. Everything is led by barcode scanning on the system, And as I already had mentioned, we have user-defined mode for LDTs. The instrument is small but very powerful because of these different capabilities that it has with these 2 different disks, and as I mentioned, different software usage, both in the IVD mode and then user-defined mode. The disc on the left is our 8-well disc, also known as the DAD or direct amplification disc. And so we have a line of products developed for that mode, each taking about an hour, each with a really simple workflow, which we'll talk about in a couple slides. And those are for low to mid volume throughput. And then we have our 96-well universal disc, the original disc for the system. Those are 10 microliter reactions, and we have IVDs there, as well as a lot of development for LDTs with ASRs. And those have 10 microliters, as I said, reaction volumes, but they're meant for high volume throughput. Back to our direct amplification disc for a minute, just to highlight the really easy workflow that it has. So we call it the 7 S's, so scan, 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 squirt, squirt, seal, and start. Literally, that can, I know I said it really fast, but it takes about a minute to do all of those operations when you're loading a disc. But here are the 4 simple steps. So you're going to open the tab of the disc, exposing a wedge, and it exposes both the sample loading port and the reaction mix loading port. Our kits come as 24 ready-to-use vials of the reaction mix. So you thaw one of those, squirt it into the reaction mix port, and then add 50 microliters of sample to the other port, seal the wedge, tear off the tab to indicate that you are using that wedge, place the disc in the system, close the lid, and away you go and start. So what's happening inside of the direct amplification disc, it looks really easy, but there's a lot going on. So once you have loaded that disc onto the system, we have a gantry that comes out over the disc during the run. The gantry actually has the optical system on it for fluorescent detection, but it also has a laser, which enables you to open up laser valves and allow fluids to move within the disc when the disc is spinning and pulling that centrifugal force to move fluids. So the disc is actually metering the correct volumes. So even though you added 50 of reaction mix and 50 of sample, you end up metering 10 microliters of sample and 40 of reaction mix. After you open the laser valve for sample, the fluid moves into the reaction chamber where we do a fluid check. Also very important, I wanted to highlight that. Not all systems do that. We make sure that the user has in fact added sample to the system and that it has actually reached the reaction chamber. Secondly, we do a heating step there where we're going to pop open viruses or bacteria, exposing the nucleic acids. And then after that step, the gantry is going to come back out over the disc. It's going to blow the other laser valve and allow reaction mix to move into the reaction chamber. So now you have a 50 microliter reaction and PCR cycling starts. It takes about an hour for these runs. You can load from 1 up to 8 samples. The disc is reusable, so once you've used one wedge, you can come back at another time and load other wedges until all 8 wedges have been spent. And it's overall relatively easy, and as I mentioned, our workflows for all these assays are the same. So with that, here's our current menu of assays that are available on that system with the 8-well disc as well as our original 96-well disc. So on the left, you can see we started with flu A/B RSV, and I'm happy to say assay number 2 here, HSV 1 and 2, we started with a clearance for CSF. We expanded that to genital swabs. And as of about a month ago, now we have expanded claims which include all swab types, so mucocutaneous and cutaneous, still across the wide spectrum of sample transport media that might show up in the lab. And hopefully Amanda Harrington will get here right around 4 o'clock-ish and be able to share with you her experience with that. We also have group A strep for throat swabs and liquid amines, as well as C.diff in that format. And then in development for the 8-well disc, we have Bordetella. That's currently in clinical studies. So that's for nasopharyngeal swabs in a variety of transport media as well, and will differentiate pertussis and parapertussis. We've got group B strep from enriched limb broth specimens. VZV is also in clinical studies right now. VZV is exactly like HSV. So all of those broad swab types, mucocutaneous and cutaneous, across all of those different transport media, as well as CSF. And the other beauty of that product is it runs with the same cycling parameters as HSV. So you will be able to load one wedge with HSV, one wedge with VZV, put sample into both, seal those wedges, and then run them at the same time if your patient, the doctor needs an HSV and VZV result on that same patient. And then lastly, earlier in development, we have atypical pneumonia. So that assay will target Mycoplasma pneumoniae, Chlamydophila pneumoniae, as well as Legionella species. And we are seeking claims for sputum, as well as BALs, and as well as nasopharyngeal swabs for that assay, NP swabs just for the C pneumo and M pneumo components. And then lastly, in development in the team in Cyprus is vaginitis with Gardnerella, Trichomonas vaginalis, and also Candida with hopefully a differentiation of crucii and glabrata for treatment decision reasons. And then, of course, on the right-hand side, we have some original FDA cleared and our 96 well. We have our C.diff assay for universal direct, so that allows that higher throughput if your lab has more samples showing up for C.diff screening, as well as flu AB RSV in our original H1N1 test. And last but not least, I wanted to mention our really, really big menu of ASRs for lab-developed tests. And on the left-hand side, you can see we have viral infectious disease targets, quite a number of them, as well as on the right-hand side, bacterial and fungal infectious disease targets. These have been developed usually along the way to IVDs, so these were the building blocks of the IVDs that have become available in the cleared products. And I also wanted to highlight some recent ones that have become available, such as M. pneumoniae that goes along with the C. pneumo, and then look for Legionella species coming soon. And I also wanted to highlight some tick-borne ASRs that will be available soon for Borrelia species, Ehrlichia species, and for Anaplasma phagocytophilum. So you can come talk to me after this if you'd like, and if you're interested in those. We also have Plasmodium species and Bartonella species in development. Okay. So with that, it's my pleasure to introduce our first speaker today, Dr. Jacky Chow. So Dr. Chow has a master's in bioengineering from the University of California, San Diego, and completed his PhD at Albert Einstein College of Medicine in the Department of Microbiology and Immunology, followed by completing his clinical micro postdoc work at University of Washington, Seattle. Since 2015, Dr. Chow, he's not that old, as you can see right here. He's really quite young. Sorry, Jacky. He's been the technical director of the Infectious Disease Diagnostics Lab at MultiCare Health System in Tacoma, Washington, where he oversees microbiology labs at Tacoma General, Mary Bridge Children's Hospital, Good Samaritan Hospital, Auburn Medical Center, as well as Allen Moore Hospital. And the title of his talk today is New Guidelines on Diagnosis of C. diff Infection, One Size Fits All. And so it's my pleasure to introduce Dr. Chow to talk to us about these new guidelines.
Hello? Can you guys hear me? Okay? At the back? Okay. So thanks, Michelle, for the introduction, and thanks, DiaSorin, for organizing this workshop and also for the opportunity for me to speak here. So as Michelle mentioned, I'm going to talk to you about C.difficile, and this is my disclosure. So Clostridium difficile now has a new name as Clostridioides difficile. Now I want to ask the audience, how many of you are aware of the new name as Clostridioides difficile? Okay, some of you, good. Now, it is a gram-positive spore-forming bacillus, and this anaerobe can be found as part of the gut flora in a small population of healthy adults. It is more common in small infants, and colonization rate can be as high as 70% depending on the age. Certain strains of C. difficile produce toxin A, toxin B, binary toxins, or a combination of the above. These strains that produce toxins can cause C. diff infection or CDI. The disease severity ranges from self-limited diarrhea to complications such as toxic megacolon, and in certain cases, it can be fatal. Now, in the United States, oh, Harry Potter, it's here. Amazing. Get it? No, that's okay. That's okay. So in the United States, every year we see about 500,000 cases, and about 65% of them are healthcare associated. Previous hospitalization, antibiotic exposure, age, also immunocompromised status are some of the known risk factors for CDI. And this disease not only causes a lot of impact on patient care and public health, but also it costs a lot of money for our hospital system too. In the laboratory, we have 5 major ways to detecting C. difficile. Toxigenic culture being one of the classics, it's often used as the gold standard because of its high sensitivity. And the flip side of the toxigenic culture is relatively long turnaround time. The second assay, cell culture neutralization assay, it's a specific assay for the toxin. The sensitivity, on the other hand, depends on the specimen condition and also depends on the storage condition. Because the toxin is actually heat labile and it can be inactivated by certain intestinal enzymes. So in order to make the cCNA works, the transportation of the specimen to the lab and prompt setup is very, very important. The process, though, it's quite labor-intensive, so therefore, these days, you don't see the test being performed in most clinical labs anymore. The third assay, the detection of glutamate dehydrogenase, or GDH, it's a relatively sensitive assay, but not very specific, because the strain can be producing toxin or non-toxin producing, and they would still produce the same enzyme, so therefore it's not very specific. The sensitivity of the GDH detection also depends on the strain. If it's 027 strain, the sensitivity is a little higher, but if it's non-027 strain, sensitivity tends to be a little lower. Enzyme immunoassay, or EIA, it's known to be a specific assay for the toxin detection. Again, it suffers from a not too high of a sensitivity. The good thing about EIA is it's easy to perform and it has a very fast turnaround time. Last but not least, we have the PCR, which is pretty sensitive and specific. However, depending on the type of PCR that you perform, it can be quite costly. So as you can see here, we have different methods or approach that we can detect C. difficile, and each of them seems to come with their own pros and cons. And among those 5 assays, these 2 are the main focus over the couple of years, and people have been asking questions such as, is PCR actually too sensitive? Should we actually use the EIA that is a little bit more specific? Should we focus on the gene, or should we focus on the toxin itself? Should we use the standalone PCR test, or 2-step or even 3-step algorithm that use the EIA toxin assay base? So last year, JCM published a paper, a point-counterpoint paper written by Dr. Fong, Dr. Palage, and also Dr. Wilcox. And they basically, in the article, they talk about the pros and cons of different methods, essentially PCR versus EIA-based algorithm. And it was a pretty thorough review article or opinion type of article. And how many of you have read this article? Raise your hand. Some of you guys. So if you haven't get the chance to read the article, I would highly recommend that, because when I was reading the article, I feel like I'm watching Star Wars. With Dr. Fong stand for the PCR, and then Dr. Palage and Dr. Wilcox are advocates of EIA-based algorithm. And I basically just looking at the paper, reading the paper, they're like fighting back and forth with their own references, and then what is the limitation of your study, and what is great about the specific test that I am supporting for. So it is a fantastic read. So I would highly recommend that. Now, what did the editor say about the author's opinion? So this is what Dr. Gilligan at UNC Chapel Hill said. Because of the uncertainty of which testing approach is most accurate in predicting that a patient has CDI, it is clear that pre-analytic considerations are essential in determining who should be tested for CDI. So Dr. Gilligan is very smart of not jumping into this very active discussion and stayed to actually go with the pre-analytical consideration, which I feel that is an absolutely right thing to do. Because C. difficile infection is a clinical diagnosis supported by the lab result. And it means that even if you have a positive C. diff result, that doesn't mean the patient must have CDI, okay? And there is no single test or no single test algorithm that can distinguish between colonization and CDI. It means that the clinical presentation and the clinical factors must be considered in order to accurately diagnose CDI. Now, for the next two slides, I'd like to do a quick review of the 2010 guideline by IDSA and SHEA, and just to go over what we have known since then, okay? It may be a little dry to just list them out, so the way that I designed to do it is a one-man role play. So I'm gonna be the dog and the lab. And some of these dialogues, you may find it actually familiar, and you may have seen it or have come across it from different providers before. So the dog was asking, why did you cancel my C.diff testing? We received a form stool. That's not possible because my patient said he had multiple episodes of diarrhea and you need to run the C.diff test for me. Does the patient have ileus or toxic megacolon? No, but he has diarrhea, so he is going to have C.diff. You need to test it, and the stool cannot be formed. All right, I guess you can cancel the test, but I have another question for you. Another patient of mine had a positive result last week, and she's now asymptomatic, but I want to make sure her C.diff is cleared. Test of stool from asymptomatic patients is not recommended because it's not clinically useful, and we do not recommend test of cure. What about repeat testing on a previously negative results? Repeat testing during the same episode of diarrhea, it's of limited value. So how do we know if the negative result it's not because of the sensitivity of the assay? That's a good point. It is possible, so therefore clinical evaluation is very important. If you're not telling me the answer, why would I need to test? So to summarize the 2010 guideline, basically we don't want to test any form stool unless the patient is suspected to have ileus or toxic megacolon. We do not recommend test of cure. We do not do repeat testing unless it's a different episode or different onset. Okay, so now we are moving on to the 2017 guideline by IDSA and SHEA. It boils down to one figure, which is figure 2 in the CID paper. This is what IDSA and SHEA recommend. If your hospital or if your institution has a good screening mechanism for the right patient, for the right specimen, then you can either choose standalone PCR or you can also choose EIA-based algorithm, okay? But if you do not have a good mechanism to rule out the colonization by what kind of diarrhea they have, do they have a significant, clinically significant diarrhea, which is defined as 3 or more watery stools within the past 24 hours, then they would actually recommend an EIA-based algorithm, okay? So if you have a mechanism to screen for the right patient, you can choose either PCR or EIA-based algorithm. If you do not, then they recommend you to use the EIA-based algorithm to limit the detection of colonization, okay? Now, how well can we actually trust the data? Of course, we know that all these recommendations, they are based on published literature. And by looking at this table, it may look a little small at the back, but I will kind of describe it for you. So the number of subjects depends, it has a pretty wide range, ranging from like 150 subjects to almost 12,000 subjects. So it's more like tenfold difference in terms of number of subjects. And then some of them, they may not have good enough statistical analysis. They may be conducted in a single site rather than a multi-site, multi-center study. Some of them, they may have more follow-up than the others. So depending on the reference that you are looking at, you may come up with different interpretation. And because of that, the recommendation that I just mentioned based on the screening, it's not a strong recommendation by the IDSA. Okay? So it is a fairly weak recommendation, and as pointed out by the counterpoint paper, we don't have very good consensus in terms of the methodology to detect or to diagnose CDI. So as Master Yoda said, future is still difficult to see, but we will stay tuned and be patient. Now there's one thing that we and the IDSA guideline all agreed on, which is the pre-analytical consideration. We should focus on testing the right patients and testing the right or appropriate specimen. Whenever we had a patient with clinically significant diarrhea, then it may be a better patient group to test on. And if it's a neonate or infants that is less than 12 months old, then we should not test them because of the high colonization rate. We should not test any repeat specimens within 7 days unless it's a new onset. And also no test of cure. So some of these points, they have been already brought up in the 2010 guideline. But say, for example, the no repeat testing, now they do have a defined days, which is 7 days, which they did not mention in the previous version. I cannot emphasize enough that appropriate testing and reporting of C.diff infection actually starts at the bedside, but not the laboratory. We have to work very closely with our colleagues, such as ID providers, our ID pharmacists, and also infection preventionists. We have to work very closely with them to make sure the testing is done appropriately. Say, for example, if the lab receives a watery stool from the floor, and based on the result or based on the request, we know that the patient has not been tested over the past 7 days, and it's watery, and the patient is greater than 2 years old. So according to our protocol, we have to test them because our techs do not necessarily see the clinical part of the patient, right? So based on the consistency of the stool sample and the age and no repeat testing, then we have to test it. And guess what? The patient was actually on laxative. So, and that is something that cannot be defined or determined by the lab. It has to start at the bedside, and therefore I cannot emphasize more. It starts at the bedside, and we have to work very closely on the clinical partners. So for the next couple of slides, I'd like to tell you what we stand in terms of appropriate testing versus not, and what kind of measures people have done to prevent that to happen. So this paper came from a study conducted at Northwestern Memorial Hospital in Chicago. And within a year, they reported 168 cases of hospital onset of CDI or hospital-acquired CDI. And they went back and looked at the chart review and see whether those test results make sense or not. Now, by making sense or not, I mean, are they clinically significant? Do they have enough or sufficient documentation of the patient's status? As you can see here, there are about 15% of them that actually classified as inappropriate testing, meaning that the patient didn't even have diarrhea. Or the test was ordered because they want to make sure it's a test of cure. And then 5 of them, they were onset before 4 days of the hospitalization, so therefore it actually does not meet the CMS criteria. Now there are about 20% of them that seems appropriate, meaning that they have clinically significant diarrhea with 3 or more watery stool over the past 24 hours, and they couldn't find other causes of diarrhea. So they think these 20% are legit. Now, what was amazing to me is that there are about 65% of them that they do not have enough information to analyze. So either there were poor documentation of how many episodes of bowel movement, or they actually identified an alternative another disease causing etiology. So, for example, if it's a Salmonella positive or Shigella positive mixed with a C. difficile, okay? And if you look at this, we are talking about 170 cases here. Only 20% of them are classified as appropriate on a retrospective study. This is like almost 70%. And if you think about this, break it into half and distribute it to inappropriate and appropriate. By screening the right patients, you almost reduce 50% of the inappropriate testing. Does it make sense? So this is the first example. Now the second example, this study was done at Hopkins, and the gray bar here, so they conducted study for 1.5 years. And the gray bar, the light gray here, it's indicating the true CDI rate. The dark gray bar here, it indicates the lab reports, the lab reported events to the CMS, meaning that this is the official number. The dark gray is the official number. The light gray, it's more like a retrospective number that they can refer back to. And you can tell almost right away that the true hospital onset CDI, it's less than the one that they reported. And upon chart review, they find out 42% of the lab reported event, they're actually non-true, meaning that the patients didn't even have clinical significant diarrhea. Not only that, out of those inappropriate testing, 92% of them, those patients were actually treated because of the reports. So now we're not only talking about the misreporting of test result, but we're also talking inappropriate treatment on the patients. I'm giving you some treatments that you actually don't need. So this is huge. This is huge. Now on the right panel here, you can also look at the light gray. This time it's going to be the lab reported SIR, which stands for standardized infection ratio. The left-hand side here, it's the dark, which is after the chart review, they think what it actually should be. And for SIR, the lower the better, okay? The study that I'm going to talk about next, it's done at UPenn, and basically in the study, they described a computerized tool to help provider discontinue the use of laxatives. I want you to focus on the second group and the third group first before looking at the first one. Now, the second group, what it means is the blue is the pre-intervention and the red is post-intervention. This group actually indicates the discontinuation of laxative also with the discontinuing of the C.diff order, meaning that they stop the laxative and then they also stop the C.diff testing. The third group here is they stopped the laxative, but they continued with the C.diff order. Okay, so this one, it's both of them get discontinued, and then the third group is only the laxative was discontinued, but the C.diff order was still performed. And as a result, you can see post-intervention, they have recorded a huge number of discontinuation of laxative. And as a result, the inappropriate testing of C.diff test was also recorded, as pointed out on the first group here. At University of Virginia Health System, they have developed this algorithm on the ordering system. And basically, there are two parts regarding this algorithm. The first part is, has the patient been tested within the past 28 days? If the patient has not been tested for the past 28 days, then you can proceed with part two, which is more like a screening for the clinical criteria, including how many stools do you actually have? Do you have any other symptoms of C.diff infection? Do you have any fever, elevated white count, or any abdominal discomfort? And all of them, if they are yes, then there's no further prompts and you can proceed with the testing. However, if you say no in some of them, then you may be prompted to cancel the test. So by doing this, they were able to prevent quite a number of inappropriate testing, which accounts for 41% of reduction. And if you look at the panel on the right, you can also see the hospital onset CDI was also reduced by 31%. So just by doing a screening during the ordering process, people have been reported success in lowering unnecessary testing, inappropriate testing, and also the hospital onset rate of CDI. Now, this study was done at Stanford and was published last year. They have done something quite similar, but even better. It is real time. So this is actually a real-time control or monitoring by the lab in terms of the, how appropriate the specimens or the testing was. So the EPIC program was able to show the date and time of the bowel movement, stool consistency, the laxative use, and actually which type of laxative that they use. And then the lab technologist can actually cancel the test order based on this information. And if the patient does not have enough stool episodes, or if they have received laxatives within the past 48 hours, then the lab tech can actually cancel the test order and notify the provider. So they are given the power, the authority to make this decision based on this information available on EPIC. And as a result, the number of tests has gone down post-intervention, and the CDI rate has also gone down. The use of vancomycin was also gone down. So this is real-time. Another real-time automated criteria verification system was done at UC Irvine, and the system are quite similar. They set up 5 rules, essentially same thing, 3 or more watery stools. There is no alternate cause for diarrhea, no laxative use, no previous testing, and an age restriction. Providers are required to attest to rules number 1 and number 2. Criteria 3 to 5, they actually auto-populated to the ordering screen. And if there are any contradiction in one of these 5, they will be prompted to a hard stop. Now, the provider can challenge the hard stop and talk to the ID or the GI doctors and get the approval. And if the test is approved, then they can go ahead and do the test. But if they are not and being insistent of doing the test, then they would get a letter from the chief medical officer. Okay? So they actually get a support, a very strong support from the hospital leadership to reinforce the appropriate testing and reporting of C.diff infection. Now, I would like you to focus on the bottom panel first, which describe the reduction of laxative use after the intervention. So no laxative here has been dropping, laxative use has been dropping, okay? And then now, back to the top panel, the dark bar indicates the hospital onset cases, and you can see after the intervention, this timeline here, the dark bar has also decreased. So we know that the hospital onset CDI, based on this real-time criteria verification, it actually works. So far I've shown you laxative use seems to be a big problem in the hospital because obviously if the patient is given laxative, then they're going to have diarrhea. So you can tell at least we have 4 or 5 institutions that have been working on monitoring and stopping laxative use before you can proceed with the CDI testing or C.diff testing. There's one more thing that I would like to point out is now we have more and more availability in terms of the multiplex PCR, and in certain PCR, multiplex PCR, the C.diff target is also on there. So we need to be very careful when we have a multiplex PCR that detects C.diff on the target, and if C.diff is co-detected together with other enteric pathogen or viruses or some other etiologies, then the interpretation needs to be taken more carefully, because it can be that the C.diff actually is just colonizing, but the diarrhea is caused by some other etiologies. Now, of course, it depends from case to case, but I'm just saying if you have a co-infection being detected by the multiplex PCR, the resulting interpretation needs to take place more carefully. So the last part of my talk, I'm going to tell you a little bit more on how we have done what we have implemented at MultiCare Health System. So MultiCare Health System, we serve 8 hospitals and about 200 clinics in the Washington area. And we do have a centralized micro laboratory at Tacoma General Hospital. The first part of our test algorithm should be familiar to you, meaning that we only test for watery and formed stool unless the patient is suspected to have ileus or toxic megacolon. We don't do any repeat testing within 7 days unless it's approved by the ID. We don't test for cure. We don't test for anyone less than 1 year old. And if it's between 1 year old and 2 years old, we would have to get the approval from the ID, GI, or myself. And in our system, we use standalone PCR. On top of that, we also developed guidelines specifically for providers and nurses. So we have 2 different guidelines, one for provider, one on nurses. The material you can say are very similar, but the way that we present it in a flowchart, it's different because obviously they have different roles and the thought process, the decision-making process are also different. I monitor weekly on all the rejected or canceled tests, and then I provide those feedbacks back to the infection preventionist. And then the infection preventionist, they would then follow up with the frontline staff and tell them, hey, you have sent us a form stool, and that is not appropriate. And if needed, I can also loop in our chief medical officer to offer help. We also developed a computerized tool on Epic for best practice alert and also set up some hard stop. It is age dependent, and we try to reiterate the importance of the clinical criteria and also no form stool testing. So this is an example of the screenshot. This is not what actually Epic shows, but this is during the development phase when we design the algorithm. So layout may not be exactly the same when you see it on Epic. But essentially, we have the BPA here saying repeat testing within 7 days is not clinically useful. We don't recommend test of cure. And also, C.diff testing should not be performed if the patient has been on laxatives for the past 48 hours. Now, in the future, we're going to put these laxative use as a required questions that the provider needs to attest before they proceed with the order. But right now, we don't have that yet. And then down here, you can see, in order to have the test order to proceed, the providers have to check whether the patients have 3 or more watery stools, or if they are standing on form stool, the patients probably will have severe ileus or toxic megacolon. And then down here, this one is more specific for children that is of age between 1 and 2 years old. And we also have a comment that they can put on, say, we want this age group being tested because the patient has a chronic GI condition or if the patient is immunocompromised. So the second criteria here is actually age-specific. And by implementing this algorithm and educations and monitoring of form stool and feedback to the frontline staff, this is our baseline from 2013 to 2015. This is a 2 years of period. This is the baseline. And we had our very aggressive education and reinforcement. Our rate have dropped down, decreased like very significantly. And this is when we introduce our computerized tool. So far, our numbers have continued to drop, and we are very proud of this because, as you can see here, we focus on the pre-analytical consideration rather than focusing on the choice of which methodology. Because you can always find a fan of PCR versus EIA-based algorithm. And even within our hospital system, occasionally some of my doctors, including ID docs, will come to me and ask me, I would like you to use the EIA-based algorithm. And then I would just tell them, look at the data, look at what we have achieved, look at the focus of our institute and the strategy that we have been using. It actually is working. And this is another figure to show you the total test, the number of total test order has been decreasing. This is 2016 and has been decreasing. Negative have been decreasing, while the positivity rate is about the same. And also you can see the number of canceled tests has dropped to almost none. So it again shows you we have been, before the implementation of these educations and reinforcement, we have been over-testing. These are all inappropriate testings. So in summary, C.diff infection is a clinical diagnosis supported by the lab results. One should not just rely on the test result to determine whether a patient has CDI or not. Depending on the patient screening mechanism of an institution, you may want to employ different test methodologies or algorithms. Inappropriate testing for C. difficile is very common, and therefore we should focus on pre-test or pre-analytical consideration. So before I finish here, I just want to throw it out a little bit. You'll be surprised the fine details of what people want to talk about and question in terms of the guidelines, in terms of the policy or the SOP. You'll be very surprised how deep they actually go, including choosing of the right word. And it doesn't really matter which word you choose. You're not going to please everyone. So that kind of echo back to my topic, right? One size does not fit all. So I would like you to really think about it and think what is the most important for patient care, what is the best fit for your own institution, and there is no right or wrong answer. And CDI is never black and white. That's the challenge. So with that, I'd like to thank you for your attention, and I'll be happy to take questions. Hi.
Hey, Jackie. Thank you. Great presentation.
Thanks.
Francis Valencia Shelton, Ascension St. Vincent's, Jacksonville, Florida. So I wouldn't forget. So no way is the right way. We actually implemented something very similar to what your institution did. We have it in our LIS system to where the doctors see greater than, has the patient had greater than or equal to 3 stools within 24 hours, laxatives, et cetera, as a screening. And it's worked very well for us. We went from a 16% rate of C. diff infection to we're about 4% now. So it was a great success for us. We, however, are not doing PCR first. We're doing the EIA first. So kind of what the new guidelines are saying, if it's working for us, then great. However, a conversation I had just right before stepping into this room was, well, what about for the EIA first? Those colonized patients that are shedding in your hospital, you know nothing about, and they're spreading the C. diff. What do you have to share for that?
So to my understanding, I know that certain hospitals do use EIA first and then PCR. But those hospitals, a lot of them, they're actually pediatric hospitals, which they already know that they have a very high colonization rate. So that's why I find it reasonable to use a not so sensitive EIA to begin with for the peds population. Now, for adult population, I would, prefer PCR first and then confirmed with the EIA. However, we know that the EIA sensitivity is not as high as the PCR. So now you have a dilemma of positive PCR, negative EIA, but how do you know if the EIA negative result is actually come from non-toxin producing strain, or it's because of the not so good sensitivity of the EIA assay?
Right. Okay.
Yeah.
Thank you.
Sure. Any other questions? Yes, go ahead. So right now, if the patient has suspected EDS or toxic megacolon, we would still run it on our PCR platform. So we don't have a different protocol for that. I saw Dr. Harrington, it's behind us. Thank you so much.
Okay, so it's my pleasure to introduce our second speaker today, Dr. Amanda Harrington, all the way from Chicago. And I'm so glad to see you here, Amanda. Thanks for coming. Dr. Harrington completed her PhD at the University of Kansas, followed by completing her clinical micro postdoc work at the Department of Lab Medicine at University of Washington, Seattle. And then she served as clinical assistant professor at the Department of Laboratory Medicine, University of Washington, followed by assistant professor of pathology at the Department of Pathology at University of Illinois, Chicago. Dr. Harrington has been at the Department of Pathology and Lab Medicine for Loyola University in Chicago since 2016, and she currently serves as the director of the Clinical Microbiology Laboratory. The title of her talk today is Addressing Unique Sample and Data Needs Associated with Neonatal and Infant HSV Diagnosis. And here she is, Dr. Amanda Harrington.
Well, hello, everyone. Good afternoon. Oh, what did I do? Oh, there we go. Okay. I wanted to thank DiaSorin for inviting me to speak here today, Michelle and Tiffany for making all my arrangements, and for thank American Airlines for my fashionably late and untimely arrival here today. So nothing like the adrenaline. These are my disclosures. And like many of us who direct clinical laboratories, one of the factors that helps us initiate or often prompts us to initiate an investigation to look into new technology is a clinical case or a clinical inquiry that comes in. You know, we're always interested in new technology, but these clinical cases that are tied directly to a patient often prompt us to really do a deep dive. And that's the case here for my experience with neonatal HSV infection. And we had a baby born in our hospital who was being evaluated for the potential of infection, had some culture results cooking, and of course it was over a holiday weekend. And the doctors are getting ready to discharge this baby. And, you know, like many of us resource-strapped laboratories, we've minimized our virology laboratories, or maybe they're done in another location. We don't have weekend services, and that was the case for us. So we had a baby that ended up getting 3 or 3.5 days extra stay in the hospital because we really couldn't assess these virology cultures. We tried to call people in, but holidays are what they are. And so, you know, if you haven't taken a deep dive into neonatal HSV lately, because maybe this is done in another section, or you haven't looked at culture, your culture practices in a while, it's a good time to maybe review that. And so today I wanted to give a nice overview of some of the pieces of the puzzle that go into this diagnosis, and start with just looking at the clinical manifestations for neonatal HSV disease. I wanted to talk specifically about the current recommendations for the utilization of diagnostics, because that's primarily where we get involved in the laboratory, and then really talk about the role of PCR for the diagnosis, because it's not as straightforward as it sounds. So HSV, herpes simplex virus, is a DNA virus, and we normally get infected through direct contact with other humans who are infected and inoculation of the mucosal areas, typically the oral, genital, or conjunctival regions, or potentially other breaks in the skin. And this is a virus, remember, that infects our sensory nerve endings and then is transported up the axon to establish that infection and establish latency at that dorsal root ganglia. So this is a virus that will remain with the host for life. And throughout the course of that lifespan, the virus will reactivate and then get transferred back down to the superficial sites where we have a clinical manifestation of infection, recurrent infections of the host. And so this is problematic over the course of the life of the host, but also can potentially be then transmitted to the fetus, neonate infant from that host, either transplacentally or through ruptured or seemingly intact membranes. And that's part of the issue here with this. We don't always know when those barriers have been disrupted. So for HSV epidemiology, we have a little bit of good news. The National Center for Healthcare Statistics, in their recent survey of the data, shows that the seroprevalence for both HSV1 and HSV2 are decreasing, so that's good. So we've dropped down to 48.1% in the 2015 to 2016 data review for HSV1 and down to 12.1% for HSV2. Notably, both types are higher in females, and that increases linearly with age. So the older we get, the more HSV infection that we see in women. And there are some significant differences between, based on different race and ethnic groups. We find the highest prevalence here in the United States of HSV1 in Mexican Americans, and the highest prevalence for HSV2 in non-Hispanic blacks. But with that, kind of the flip side of the coin is that HSV1 is now becoming the most predominant cause of genital HSV. And so this is a virus that we've typically known to be acquired in childhood. You establish a certain amount of seroprotection, but now with infection being established later in life, and because the prevalence has declined, those young people lack antibodies, and due to some changing habits and sexual behavior, they're now more susceptible to contracting genital herpes from HSV1 at sexual debut. So we've realized that about 60 to 80% of the new genital infections are due to HSV1. Some good news is that it seems that HSV1 is less likely to reactivate in the genital tract than HSV2. HSV during pregnancy, of course, is significant. About 20 to 30% of pregnant women in the United States are seropositive for HSV2, and about 3/4 of those women will have a recurrence during pregnancy. So that's significant for transmission to the fetus. If you're seronegative at the time of pregnancy, you have about a 4% chance of being infected with either HSV1 or 2 during that time period. But if you've been previously infected with HSV1, there is some seroprotection that reduces at least a little bit the risk of acquiring HSV2 during pregnancy. I think the most notable point is that up to 80% of the cases of neonatal HSV, there's no known maternal history of HSV. So the mother doesn't report any clinical manifestations consistent with HSV disease. So this is kind of a big hole when we go into prenatal care. And we know that women who do become infected during pregnancy are significantly more likely to transmit that virus during that primary infection period as opposed to recurrent infection. So we talked about HSV1 being less likely to recur in the genital tract, and so that's a good thing. So that's another piece that helps reduce risk to the fetus. But this increased risk of transmission to the fetus is probably twofold. One, that we have lower concentrations of antibodies at the time of primary infection that can be transplacentally transferred to the baby for protection. And we also know that higher quantities of virus are shed for a longer period of time during that primary infection phase. And interestingly enough, as women come in for their visits, their prenatal visits, many women, and not just prenatal, pregnant women, many women with the first clinical episodes of symptomatic herpes are actually experiencing a reactivation, that the first infection was actually subclinical and went unnoticed. So the secondary infection is what's actually being noted at that presentation. So how do we assess that? How can we assess whether this is a first infection or a recurrent infection? We can use some of our diagnostic testing in the laboratory to help classify that maternal stage and help stratify risk for the baby. So we can use a combination of either detection or isolation of the virus through PCR or culture-based methods, and we can use maternal serology. So you can see in this chart here, if we find evidence of the virus either through PCR or culture-based methods, but the mother's negative serologically, that's the classification of a first episode primary infection. So likely that the mother has acquired the virus recently. If we have, evidence of either HSV1 or HSV2, but find the opposite in our serology evidence, that's classified as a first episode non-primary infection. And if the serology and the culture or PCR are concordant, that's evidence or classification of a recurrent infection. And so in the absence of any of the diagnostic evidence, as we can see here, if we don't have that information, you have to assume that this is the first episode and that this is the highest risk. So how do we translate that information about what we know about the mother and the diagnostic information to expected risk in our neonates? And so we know that if the infection is classified as a first episode primary infection, there's a high likelihood that the virus will be transmitted to the neonate, somewhere around 57%. If it's a first episode non-primary infection, that risk drops significantly to about a quarter. And if it's a recurrent HSV infection, risk drops much lower to 2%. And there are several other factors that can impact whether or not the virus will actually or potentially be transmitted to the baby. The type of delivery, so vaginal versus cesarean delivery, where cesarean delivery is thought to be more protective to prevent the transmission of the virus. Now, it's not 100% protective because babies have been delivered by C-section and still had evidence of transmission of the virus. Time to delivery of the rupture of the membrane, so that 4-hour mark makes a difference. Post 4 hours, rupture of membranes, time to delivery increases risk of transmission of the virus. We know that broken mucocutaneous barriers, specifically one example is use of those scalp electrodes that they put on the top of the baby's head to monitor fetal progress during the perinatal period. So that's been associated with a risk of transmission of the virus. And if it's an HSV1 versus HSV2, with HSV2 being more likely to be transmitted. So with all of those pieces of the puzzle and all of those unknowns, neonatal herpes is still relatively rare here in the United States. The rate is about, at least the last time we looked, about 9.6 per 100,000 births here in the U.S., which is about 1 in 3,200 cases, and that translates to roughly 1,500 cases annually. So although it's a low event, it's a rare event, it's significant because it's associated with significant morbidity and mortality, and it's also devastating for parents and families when this happens. It's one of the toughest conversations when you read and talk to physicians, one of the toughest conversations that they have to have with their patients. So it's also important as we're having this discussion about the different pieces of the puzzle to distinguish the definition between infection versus disease. So infection is that viral replication has been established, but the virus is not causing illness. And this is most often how we encounter the neonates. We're in this asymptomatic period where we're trying to assess whether the baby has actually been infected. And in the definition of disease is that viral replication is actually producing clinical signs of illness. But once the baby has been infected, progression to neonatal HSV disease is virtually certain. So the number one thing we're trying to do is prevent that transmission, prevent that infection. So how do babies, when do they acquire HSV? There are 3 time periods that typically we think of. In utero, which is not predominant, the peripartum period, which is either just before or during delivery, and that's the significant majority of transmission events, and then the postpartum event. So we talk primarily today about neonatal HSV, but remember that we're defining the neonatal period as just those first 4 weeks. So anywhere after that, it's really translating into infant disease. And so transmission during the utero period, babies are typically born with these severe chronic manifestations with skin findings, neurologic findings, and ocular findings at birth. So that transmission is evident upon birth. But it's very difficult to distinguish clinically the difference between peripartum and postpartum just based on the clinical symptoms. It's just primarily the timeline of the acquisition. So there are three clinical manifestations of HSV disease in the neonate: the skin, eye, and mouth, which accounts for about 45% of disease. Central nervous system disease, which is about 30%, and disseminated disease. And the average onset is somewhere between 1.5 and 3 weeks of age, but this can vary quite a bit depending on different babies and other factors. So I wanted to just review each of those clinical presentations. The skin, eye, and mouth disease, and like all of these, can appear benign at the onset of illness. Babies may not present with any clinical identifying features. Skin, eye, and mouth disease is associated with a high risk of progression to this central nervous system or disseminated disease without therapy. So diagnosis is important, but also guidelines and assessment of risk is important in terms of how we treat these babies. And this typically presents, we see this show up within the first 2 weeks of life. So remember I said that the average was 1.5 to 3, but this can be in the first 2 weeks typically. Presentations that involve the skin are typically localized, and we see areas of clustering vesicular lesions with an erythematous base, often on the arm or anywhere on the body, but we also see that lesion with the scalp monitor, if that's been placed as well. That's a common sight to see. Eye infections can often present with watering of the eye. The baby may appear to cry from pain, and we also can see conjunctival erythema. And then a more severe presentation of keratoconjunctivitis may progress to cataracts and chorioretinitis. So that's a more severe presentation of eye infection. Mouth sores and ulcerative lesions on the palate and the tongue as well can also be seen in this clinical presentation. Central nervous system disease typically presents a little bit later in the 2nd or 3rd week of life. And interestingly, as we look at these clinical presentations, you'll start to notice there's a little bit of a Venn diagram. And as I was going through this, I realized that probably would have been quite helpful to use that. 60 to 70% of patients with this type of disease also have skin vesicles. So the clinical symptoms and the diagnostic features that help characterize this type of clinical presentation might not show up in early disease. And initially, babies may present with very vague symptoms like lethargy, irritability, poor feeding, and that can be common in newborns for a number of different etiologic agents. They can go on to progress to seizures, temperature instability, so being hot and cold and not maintaining their temperature, and a full anterior fontanelle. And diagnostic features as well can be varied as well. In these cases, it's important to get a cerebral spinal fluid sample, and as we analyze that in the laboratory, we should expect to see a mononuclear cell pleocytosis. We would see a normal or moderately low glucose concentration and a mildly elevated protein. Interestingly as well, when we look at imaging and other monitoring technology, so our EEG is often abnormal early, but our imaging like MRI and CT may be normal. So this may be a diagnostic challenge in the laboratory, and it may be indistinguishable from other causes of neonatal sepsis or meningitis. Disseminated disease typically presents in the first week of life, so this can be very early on. And again, the signs can be nonspecific, just like the other clinical presentations. We may see other organ systems involved as we see manifestations of respiratory distress, infection in the lung, abdominal distension as a source of GI infection, hepatomegaly, and ascites as the liver gets involved. And because of these diagnostic vagaries, the diagnosis may be delayed. You can see there's a long list of multiple organs that are involved here, and we can have multi-organ system involvement in disseminated disease. This is probably one of the most severe presentations, and mortality is very high if untreated. So early diagnosis is important, along with guidelines for therapy. So how do we diagnose neonatal HSV disease? I'm going to talk today about the guideline recommendations for the American Academy of Pediatrics, and these were established, this round of guidelines was established in 2013. But I know that the Red Book guidelines are also coming out. I haven't seen the new 2018 publications, and I think there's a little bit of revision in there, but I'm going to focus on what's been published. So they recommend utilization of surface cultures, and I'll talk a little bit more about that. Specimens from skin vesicles, if those are present, so if there are evidence of skin vesicles, we need a sample from that, and CSF for HSV PCR. Also whole blood or other blood plasma potentially for HSV PCR, and blood for ALT, so liver enzymes. And depending on the clinical presentation of the neonate, there's a long list of diagnostic testing we should also consider as well. Often we want to assess, of course, blood count and liver function, CSF, but do ophthalmologic examination if necessary, and include other neuroimaging and electroencephalogram monitoring. This can be challenging in neonates, especially because we have minimal amounts of volume for fluids that we can work with. So for blood, especially in newborns, we're getting teeny tiny amounts, and cerebral spinal fluid, we're getting teeny tiny amounts. So when you're trying to do a comprehensive workup, not only for this, but the other things that can be on your differential, that can be diagnostically challenging for the laboratory. So surface cultures, what is a surface culture? We're actually getting a swab sample from the baby, and you want to collect this 12 to 24 hours after birth, not sooner. It's recommended that you can do either multiple swabs or one swab. You can combine your swabs into one tube. And if you're doing one swab to swab the mouth, the nasopharynx, conjunctiva, and leaving the rectum for last. So we talk about swabbing the baby from top down, not the other way around. So a positive surface culture, and so you're going to send this swab sample of an asymptomatic baby for culture, and a positive culture 12 to 24 hours after birth is indicative of viral replication. And the thought is that you don't want to do that sooner than that, because that could reflect contamination during delivery rather than infection. So it's important, that time point is significant. Okay, so diagnostic testing in the laboratory for detection or cultivation of HSV, we use culture and PCR. And so we know from the literature and what we've been talking about for the past, many years is that the sensitivity of viral culture is low. There's well-documented evidence that in recurrent lesions, there's less shedding of virus, and so the sensitivity of culture-based methods is much lower than PCR. That rapidly declines. The amount of virus available for detection rapidly declines as those lesions begin to heal, and so it becomes a challenge. In addition, the viral shedding is intermittent, and so a negative culture is not effective to exclude infection from HSV. And these are for patients where we actually see clinical evidence of infection. Interestingly, the sensitivity for viral culture for neonates whose mothers have already been on acyclovir, there's very little evidence out there, so we haven't been able to assess that very well. And also one other downside for culture-based methods is that they don't differentiate immediately between type. There's an additional step, and a lot of laboratories don't perform that testing on site either. So culture basics, just a short review. This might be historical information at some point. The specimen, our swab specimens are eluted in viral transport media and then inoculated onto a susceptible cell line. This is a list, and I'm sure it's not comprehensive, of some of the more common cell lines that are used in laboratories for the culture of HSV virus. And then we're looking at the cell line for the microscopic evaluation of the cytopathic effect. And so we can see the cell line here. These are actually vero cells infected with a ATCC strain of human herpes 2, and then infection demonstrated by that cytopathic effect or rounding up of the cells. Typically, it's noted that you can see this within 5 days, sometimes as short as 2 days, but may require up to 14 days depending on the cell line. Now we know that shell vial cultures have also been implemented and can also improve the speed with which we can detect this viral infection. And one other commonly used tool for virology culture for detection of HSV is this commercial model, the ELVIS, or enzyme-linked virus-inducible system. So this is a commercial cell line from Diagnostic Hybrids. And it's a genetically engineered host cell line that carries the LAC-Z reporter gene. And so that LAC-Z reporter gene encodes for the beta-galactosidase enzyme. So once the HSV infects the cell and it infects and induces the expression of that LAC-Z gene, there's production of the beta-galactosidase, and that enzyme then cleaves a colorimetric substrate, and you can see that here depicted in the cells with the blue, and so that blue color is visible in the infected cells. So there you have evidence of infection, an active replication of HSV. And so the positive ELVIS cell culture line can detect HSV within 24 hours of inoculation. So diagnostic testing for CSF, PCR is the method of choice, hands down. We've known that for quite a while. Culture has an unacceptably low sensitivity for detection of HSV from CSF, so you have to use PCR. Interestingly enough, you may find a false negative early in the disease course, and so this might be something to keep in mind in our laboratories. Often we're doing tighter control, and Jacky talked about this today, tighter control of our repeat number of assays to watch for cost and hopefully prevent false positives downstream. But this is one case when you would want to allow a repeat test within a short period of time. So if you have an initial test, a repeat viral assay for the CSF specimen might be helpful in this case. Detection of HSV is confirmatory for CNS diagnosis in this case. We know that the baby may or may not have clinical symptoms or other diagnostic evidence. But that's also why it's really essential to have very careful analytical controls in your laboratory for these assays. A false positive can have significant impacts. We would expect to find HSV detected in each of the clinical presentations in the CSF sample. So for skin, eye, and mouth disease, we can recover HSV from the CSF in about 25% of cases. In disseminated cases, about 90%. And then even in the CNS disease, it's a range between 75 and 100%. So although detection of HSV in the CSF is definitive for this classification, we don't always detect it. HSV PCR, and so that's been demonstrated on whole blood and plasma as well. And we can see the expected detection rates here. So in skin, eye, and mouth disease, we should expect to detect HSV in a blood sample about 70 to 80% of the time. In disseminated cases, 100% of the time, although we all know in the laboratory nothing's 100%, right? So I should have said 99.9. And in CNS disease, about 65% of the time. And this was a really nice study out in 2015 that was published by Seattle Children's that actually looked at, they had been running HSV blood PCR along with their CSF PCR prospectively for quite a long time and looked to see how helpful that blood assay was. And so they found it especially useful in infants who present without cutaneous lesions. No one diagnostic test, so culture, CSF PCR, or blood PCR was the best at diagnosing each of the clinical manifestations of infection, but blood PCR detected across the board 83% of the infants had a positive result. And interestingly enough, in 5 cases, that was the only sample that was positive. So as you might expect, the surface culture had the highest rate of detection for skin, eye, and mouth disease. The blood had the highest rate of detection for disseminated, and CSF had the highest rate of detection. But across the board, comprehensively, blood was the most diagnostic. This is also an assay that not all of us have in our laboratory. We have it sent out, or maybe it's done in another section of the hospital. So how does this relate to treatment and outcome? Assessing the risk and diagnosing the clinical presentation and category helps direct the treatment and can potentially help predict outcome. So the recommended treatment is IV acyclovir, and it's recommended for treatment in proven cases, clinically suspected cases, and asymptomatic cases with risk due to exposure. So assessment of that risk is just as important as the actual diagnosis. And we know that treatment is significant, especially if it's started early and can improve survival and outcome. So you can see the mortality rates, 1-year mortality rates here before and after antiviral therapy, and so they had a significant impact not only on disseminated disease, which dropped the rate from 85 to 29%, but also in the CNS disease from 50 to 4%. So that's a significant benefit for early therapy. So we don't usually get into dosing in the hospital, but duration may have an impact on our diagnostic testing. So I put the dosing here just so you could see it, 60 mg per kg, delivered intravenously, divided over 8 hours. And it's a minimum of 21 days of treatment for disseminated and CNS disease. So here we're back to really being able to identify and define which clinical manifestation, because it will help us dictate and determine how long the baby gets therapy. The recommendation is that at the end of that treatment course that they should be assessed for the clearance of the virus from the CSF. So that's another time point where we may be expected to perform that CSF PCR assay. And if it's still positive, they're going to get more treatment, continued therapy, and they're going to monitor them weekly until that's negative. So that can end up being some extra testing in our laboratory. So I think that's just some good guidelines to be aware of when we get these repeat requests, that these are just right in line with what's currently being recommended. So I'm not going to go over this in detail, but I wanted to put it up here. So in the American Academy of Pediatrics recommendation publication, it's actually broken out a little bit more, but I stole this from Up to Date if you have access to this. It's actually a nice, concise, condensed guideline for how to evaluate and then what we do in terms of diagnostic testing and treatment for these babies. So it's going to stratify babies based on risk, the maternal presentation, and then the diagnostic testing and treatment. So I think it's a very helpful just kind of algorithm to let us know what the diagnostic testing recommendations are. So let's go back to surface swabs a little bit, because we're talking about PCR and culture and what should we do. And so that was really what came up in our inquiry. We had a baby who ended up staying in the hospital longer than expected because we didn't have the culture results available. And our first reaction was, okay, well, let's get rid of culture. That seems like the easy solution. But it turns out it's a little more complicated because of these recommendations for how to handle neonates. And the recommendations are to use culture. But if we go back and read a little bit more carefully, it says PCR may be performed in conjunction with the HSV surface cultures. So while we can't kick them out entirely, we can start to use some PCR-based testing. And like I said, I think maybe these recommendations, or this might be modified at some point in the 2018 guideline, but I haven't had an opportunity to see it yet. And so this was the information that we had gotten from our pediatric infectious disease staff, that they really didn't feel comfortable moving to a wholesale PCR assay, and they really wanted to stick with culture. But here was our issue. You know, the baby could have been released with a negative culture and had met other diagnostic criteria for being stable and other negative testing, could have been released from the hospital at 48 hours. But in the absence of that result, the baby had to stay until the culture was negative or for 96 hours. And so that was really frustrating. So what do we know about PCR versus culture for swabs? And you know, is PCR really so much better? And the problem is that there really just isn't a ton of data, especially involving neonates. And so I think that's what's preventing from the wholesale adoption of these PCR technologies for these diagnoses. So here's a study that was published out of the University of Washington, and they looked at a really large cohort of patients, looking at sampling throughout the course of their infections and during recurrences, and they demonstrated quite nicely this very linear range of where we can detect our HSV in culture and how much they were detecting by PCR. And so they found that when there was greater than or equal to 10 to the 4th copies on a swab, only about half of the time were they able to recover that in culture. And if the viral load was lower than that, it dropped down to 6%. And they saw that same disproportion, although a little bit different, when lesions were present versus when lesions were absent. So you can see those numbers here, 53 versus 5 and 38 versus 6. So at a certain level, culture really hits the limit of detection, and PCR is really essential. And these are established infections with patients with recurrent disease. But what about our babies, and what about asymptomatic shedding? And this is really the kicker. There's very little data out there. And so this was another study done in Seattle where they looked at, they swabbed patients at the time of delivery and looked at that shedding, if they could pick that up after the fact that they knew that the neonate had, the HSV had been transmitted to the neonate. And so importantly, that subclinical shedding, not only is the patient unable to assess that, but the clinicians aren't either. That there's some sort of invisible ulceration in the skin surface or mucosa that's not notable. So we're not able to assess that at the time of delivery. They collected these swabs and found significant discrepancy between culture and PCR-based detection in these samples where they knew that HSV had been transmitted to the neonate. So this is the biggest risk to the baby. It's the undiagnosed mother. And it's a real challenge. So to PCR or not to PCR, we have all these pieces of the puzzle, and how do we handle this? I'd really like to get a more efficient system in my laboratory that is more accurate, has better sensitivity, that I could run on the weekends. And so we started looking around for a solution. And so I was really excited when we came across this Infectious system to look at this. So this is an easy-to-use system, I think. It's cleared for CSF, and now just in March, also for mucocutaneous and cutaneous swab samples. And importantly, I think it can use only 50 microliters of CSF to actually run the sample. And remember, we talked about in our neonates, our teeny tiny babies, we may only get a couple of drops. And really, 30 to 50 microliters is about 1 drop out of your transfer pipette. So we're just working with tiny volumes. The other thing that's challenging for laboratories is that if you don't have a big batch, sometimes on a laboratory developed test, you need a batch minimum to optimize your reagents, and so that can be a disadvantage for hospitals that have small volumes. And so this system can actually run as few as 1 and up to 8 samples. You can deliver that result in 60 minutes, and because it's moderate complexity testing, you can potentially run this test on the weekends or on off shifts if necessary. So we're just adding reagents and samples directly to the cartridge wheel, entering it into the instrument, and I'm oversimplifying a little bit, but I feel like it's very easy to use in less than 1 minute of hands-on time. And so these are some of the data that came out from the trial evaluation for the cutaneous samples. They looked at both prospective samples and saw really nice positive and negative agreement as compared to their comparator method. So the comparator method in this case was culture, and then bidirectional sequencing uses comparators, and they used the 2 out of 3 rule to determine the final result. So we see a really nice level of agreement for both HSV1 and HSV2, and the same for retrospective samples as well. And we see that also for mucocutaneous sites as well. But more importantly, I wanted to show this information because a lot of the tests that moved onto the market for FDA approval don't often get the opportunity to evaluate pediatric patients and especially neonates. So here they were actually able to evaluate at least some samples from the neonate population and infants as well. So this is an assay that you can use for both pediatric and adult populations. But how about back to our surface swab? So remember, our average time to clinical presentation can be a week and a half and sometimes up to 3 weeks. So most of the babies that we're evaluating for risk or for diagnosis are symptomatic. And so that means the absence of lesions. We're swabbing the conjunctiva, the mouth, and the rectum. And if we look at the package insert language, I think it's pretty clear. So the package insert states that this test is indicated for the qualitative detection and differentiation of herpes simplex virus DNA present in mucocutaneous and cutaneous lesion swabs from patients with signs and symptoms. And so I think that's the key. And so this is my personal opinion, and I would be happy to hear feedback, but I think that surface swabs are asymptomatic. And so in my laboratory, I would consider these off-label. I don't think the test has covered that significantly. Because as we saw, there's a difference in the level of shedding between patients who have active lesions and who don't. And so in patients that are asymptomatic, I think we have to answer the question whether or not the test has analytical sensitivity to detect the virus. I think that's an important question, especially for this population where the diagnosis is so important. So that's where we started in our laboratory. We wanted to look at the analytical sensitivity in these surface swab samples. And so in our hospital, we were much more likely to get individual samples rather than combined. So you can see those listed here. And we had a number of them in the freezer, although this is not an extensive data set. It's what we had. We were a low prevalence population, which is a good thing. And we looked at the results in culture, which were negative, and we went and tested those specimens again with our PCR assay, and they were concordant. So that was a good thing, that our culture at least was negative, and we hadn't missed any infections. Unfortunately, this is not very helpful when you're trying to validate an assay because we didn't have any positive samples. So we moved on to doing a limit of detection assay. And so we took 4 different strains that had been quantified and did serial dilutions until we found the limit of detection concentration as defined by the TCID 50 for these 4 strains. And as you can see, these numbers are comparatively low, and when we looked at our comparative method, which was culture, it said that in the package insert, you can see here the detection is 1. So we thought that at least based on this initial kind of spiking experiment to determine limit of detection in the matrix sample, that it had sufficient sensitivity, analytical sensitivity for detection of HSV in this sample type. And I think that wasn't unexpected. You know, we were really hopeful that this new sensitive assay had been developed and we could utilize it for these sample types as well. So while this is a preliminary and limited evaluation, we did find that the assay demonstrated high sensitivity and specificity and reproducibility for the detection of these 4 strains. So that was really great. We could utilize this test because of the flexibility of the way that the assay is designed. It can be reported within just a few hours of collection and potentially on several shifts if necessary, or at least on the weekends, and can be used to facilitate treatment and primarily discharge from the hospital. I think that's the most interesting point. If we have a baby who's stable and meets other criteria, this baby could be discharged from the hospital and followed carefully at home. So we think this assay offers a promising alternative to viral culture for these neonatal swab specimens, whether we're going to run it in parallel or as a standalone test. But I think it's important especially that we definitely need more data in this analysis to evaluate whether this is effective in terms of clinical utilization, because the one thing we haven't assessed so far is the clinical specificity. So we need to go back and look at the patients, et cetera. Okay. So I think overall there are a couple of take-home points and discussion about neonatal HSV testing. We need to remember that most infants are born to mothers with no history of HSV. So it becomes really challenging diagnosis. It's multifactorial. You need assessment of risk, diagnostic testing, and we need guided therapy recommendations based on all of those factors. It's important that evaluation for neonatal HSV to include all the samples that are recommended, so blood, CSF, and these surface swabs, in addition to the other diagnostic testing that's recommended. But this quick assessment really is only effective if those tests are on site. And so that's something I think I feel responsible for working towards, is getting these tests into my laboratory so we can give those answers back within a short time frame. And it's clear that PCR can be effective and can potentially supplement or replace culture moving forward. So we'll see what the new guidelines bring, and we'll see what happens as more data comes out. So I want to acknowledge Christina Jorgvan, who did the work for these limit of detection assays. She was really great. This is the reference for the pediatric guidelines. And I'd be happy to take any questions that you have. Thank you. think that was 6 months of samples from our freezer. We didn't have a lot to work with. And so I think that was a challenge for us. If you're trying to get rid of virology culture, this is a piece you really have to think about before you get rid of it. Yeah. It is a challenge, so yeah.
So you mentioned that 50 microliters, is nice, but sometimes you get much less.
Yeah.
You would try putting less. I remember hearing Michelle saying that only really 10 microliters of sample is sucked in. So
I haven't tried that. It would definitely be worth trying. Yeah, that's a great point, and I think it's pretty clear we have to think outside of the box in this patient population. How many people have HSV PCR in their laboratories? How many people are doing CSF in some form? We do. Does anybody have blood? Yeah, we don't. It's a send out. And so I think that's a real challenge in this diagnostic area if you're not geared to be an LDT lab. We're not a lab developed test lab. So I'm really excited about all of the opportunities that the new vendors are bringing to us in terms of these quick, flexible platforms. It's really great to be part of the molecular revolution, I think. Thank you.